Hello, everyone. This is Manos Brilakis here. Hope everyone is going well. We had some AV connection issues today, so I'm going to get started. WebEx is working on the background to resolve some of those issues. But again, I'd like to thank you again for coming in today. This is the 17th VA CTO Club, and we'll discuss about 3 interesting cases today pertaining to CTO interventions. So here's the first one. This is a patient who presented with a right coronary artery CTO. He's had multiple PCIs to the right coronary artery, and actually the very last PCI prior to this current one was for a CTO itself. So he had already a CTO intervention, and unfortunately, as you can see here, he's got a complete in-stent restenosis in this native right coronary artery. Hello, who just joined us?
Yeah, hi, this is Kaushik Reddy from Tampa. How are you?
Hi, Kaushik. How are you? Thanks for joining us. A pleasure. We just had some issues earlier on with the AV, but I think we're resolved now. So thanks for joining in.
Absolutely, thank you.
And again, we have 3 cases we're going to be discussing today. This is the case of a right coronary CTO, and the patient had a previous CTO. So this is in-stent restenosis of an already previously did CTO. Full metal jacket in the right coronary artery, pretty long occlusion as you can see. This is the contralateral dual injection. So as you can tell, this is essentially coming all the way from the ostium of the right, all the way down to the PDA. And we do have some septal collaterals. There's septal collateral coming and connecting down to the PDA. Not the best. There's an epicardial collateral, which actually sometimes can be confused for septal, that goes all the way and gives an acute marginal coming all the way to the mid-right coronary. So in any case, so it looks like a fairly challenging case. Anyone has any thoughts about how to tackle this this patient? Again, you can see here, literally have virtually no vessel in the proximal part.
Yeah, I don't see the cine runs on my end yet. It says it's preparing 99%.
Oh, I see. Yeah, you're probably. Yeah, sometimes it just takes a while.
It's loading up. It's loading up. Yeah, yes, something is happening. We'll see. Yeah, there we go. Yeah.
So again, I guess if we take the characteristics, we have a kind of semi-defined proximal cap, because we see the little branch, the little conus branch, but don't really see much of the proximal vessel. So the cap is ambiguous to some degree. We do have a long occlusion. This is obviously more than 20 millimeters, fairly long. And the distal vessel is, well, I mean, not the best, but it's there. So there's a PDA, looks small, but sometimes this is constricted from chronic underperfusion. And then in terms of collaterals, we do have a septal that connects to the PDA, although it doesn't seem to be the most straightforward. Lots of tortuosity and lots of turns. So actually had a lot of debate about how to approach this case, and the consensus was to actually first try retrograde, because they didn't have much on the undergrade to work with. I don't know if people agree with that, if you would do something different. And again, the idea was to go down this collateral and then go retrograde and then probably knuckle all the way back. And hopefully, if you can get into the extent, that would hopefully prevent us from going out. Now, someone else had suggested earlier on to try dissection reentry. As you know, for in-stent restenosis, dissection reentry, it's a pretty good way to tackle the lesions, because you have kind of a metal cage, so the crosspost catheter can stay inside the stent, and not invariably, but most of the cases can cross most of it, and then using some wire escalation on the end can get you back into the true lumen. Okay, and this is the attempt. So again, here we're trying to go retrograde. This is a corsair. As you know, we now have a turnpike as well, and we have also another microcatheter, microcross. So a lot of options for going retrograde these days. And this is a selective injection. We don't always do that. Sometimes we do surfing, but in this case, because the collateral was kind of tortuous and small, we decided to do some selective injections. And this is now trying to get in. This is again the corsair. Now it's further down, and we are actually having difficulty advancing a Sion guide wire through this. So you can see on the, actually I'm sorry, this is actually epicardial. I misspoke earlier on. So this is an epicardial coming from the circ all the way into the PDA. And this patient, as you can tell, there is no sternal wire, so it doesn't have previous bypass. So obviously we want to be a little more careful when trying to cross this, since perforation could cause early tamponade. Okay, so at this point, we tried probably half an hour, and we tried multiple injections. We tried the Sion wire, we tried the field RFC, but unfortunately could not get the wire to take this extra turn. So we decided to switch undergrade. And just trying to position a catheter, this is a microcatheter, I think this is a fine cross, and having a looped guide wire, this is I think a field XT. What happened is the wire immediately went subintimal, and then just stayed subintimal outside the coronary. And before I go there, so we tried, I mean, literally for a long time, trying to get some sort of wire, Confianza Pro 12, we got the Gaia guide wire, we tried to get some entry into the stent, but I think once we got the exit into this subintimal space, then everything tended to actually follow this path. So unfortunately, we were unable to get a wire in. So I wonder how many people would just keep on going or just try to do something different at this point. And a big loop subintimal guide wire. And the bottom line is we did try for a while to get a wire into the stent, couldn't. And so we decided, well, nothing else we can do. The patient did not want to go for bypass, and plus bypass for single vessel RCA, not the best option anyway. So we decided, okay, well, let's see if we can re-enter down there. And this is the same field XT wire. You can see it's all the way down to the PDA. We're clearly wrapping around the right coronary artery. And then we thought at some point that actually the loop might have gone into the true lumen. And this is not uncommon once you have a very small distal vessel and you push a knuckle. It's not uncommon for the knuckle to actually enter into the true lumen, and that's the classic star technique from Antonio Colombo. But in this case, I don't know if you can tell, but we're clearly outside the vessel. The guide wire is on the subintimal space, essentially, of the PDA. So we switched for the guide wire, for a Stingray guide wire and balloon, and you can see the two dots of the Stingray system. Very small vessel, and these are the ones we always like to swap the Stingray wire for a polymer Pilot 200 guide wire. And what you're seeing here is we finally got into the distal true lumen. Can we have some feeling coming again still from that obtuse marginal branch. And I like this. This is a nice, cool IVUS, because you can see that we're pretty much out all the way. This is the preview stent. And now we have entry to the subintimal space, manual pullback. And you see pretty much we've gone around it all the way, around the whole stent all the way up into the proximal vessel. So we were a little concerned initially because we thought, well, it's a pretty big stent, and is it safe to do all this subintimal? But the wire was going fairly easily, so we pursued for it, and we put a bunch of stents. And it looks a little weird now because you have the old stent in some projections and the new stents kind of overlapping this one. But we did get a nice TIMI-3 distal flow. And this is how the IVUS looks like now, which is interesting. Again, I hadn't seen myself a similar thing before, but you see the old stent is crushed, It's like a semi-lunar projection. And we have the new stents essentially being inside the old stents and crushing the old ones all the way against the wall. Now, don't ask me the restenosis rate here, because I'm sure it's going to be very, very high. Would anyone bring them back for screening angiography in 3 to 6 months? Just in case there's high rates of restenosis?
What would you do differently, though, if there is, unless he is symptomatic? I probably would not bring him back for a surveillance angiography, because now, even if you were to do this all over again, potentially looking at 3 layers of metal.
True. No, but actually, you're right. I mean, if it's CTO again, I don't think we would going to do anything to it. But what sometimes happens is you have some focal restenosis, let's say, a focal 90%, and the question is, do you want to know about it before it becomes a CTO again?
Yeah, type 4, type 5.
Yeah, so I see your point. Yeah, the point is, I think it's occluded. I think we're done. But if it comes back and has a focal restenosis point, then we might consider doing something. Actually, I was thinking for this one, the ideal thing would be to have a covered, a bioabsorbable stent. Obviously, we don't have them. But once you have all these stent layers, and assuming that the bioabsorbable stent has the decent radial strength to withstand this, I think the next step would be to put bioabsorbable. Then at the end, you still have kind of some more space left there. But I agree with you. If it's a CTO again, I think we're done. If not, then maybe some other options.
Absolutely.
And actually, coincidentally, the guys from New Orleans just published, Rafeni Dal just published a similar case where they did the exact same thing. They went subintimal, crushed the old stent, and then they did follow-up angiogram at 6 months in this patient, and the patient had a patent stent. But again, in Stefan Rinfret's case series of subintimal dissection reentry, ISR lesions are the ones who had the higher stenosis rate. So clearly the ones we need to worry more about. So again, that's a case out of the ordinary, just to share some new experience we had. Going on to another case. This was a patient who came in with heart failure, essentially, and exertional angina. He had an ejection fraction of 25%. And as you can see, he's got a nice circ. You see some vessel filling up on the side. And when you image the right, then it becomes obvious that the problem here is that the LAD is occluded. So he has nice collaterals coming from the distal right coronary artery filling the LAD, and seems also to have a large diagonal on that side. So the question was, in this case, do you send him for bypass, single vessel bypass, which is obviously a good choice because we can do a single vessel lima, ideally minimally invasive, or attempt to open it percutaneously and see how the patient does. Again, single vessel disease, but the patient does have a low ejection fraction, presumably because of the occlusion of the LAD. And again, there's no right or wrong answer here, but this was a case that the patient had a strong feeling for percutaneous assessment, and we decided to offer to him. If you look carefully, so the lesion starts, it's an ambiguous proximal cap. We don't know where it starts. But the distal cap, it's a bifurcation, the LAD/diagonal bifurcation here. So we have bifurcation of the distal cap, and then we have a nice vessel more distally. And then let's see what else we can do here. Different views. Try to open up the proximal caps if you understand where it is. And in these particular views, it looks like there may be some sort of microchannel that is coming from the mid LAD all the way to the proximal. Obviously, he has a very large proximal circumflex, which is again a large vessel with a lot of side branches. And this is the patient's hemodynamics at baseline. You see he's in sinus rhythm. He's got a pressure of 140, so everything is nice and good. So we tried to go undergrade. I couldn't select that vessel, so we decided to leave a wire in the circ. So what you're seeing up here is a guide wire in the circumflex artery, and then this is a picture from the right coronary artery. And we were able to advance a Sion guide wire to this last septal, and we debated whether we should go for the more distal septal versus the more proximal septal. And retrospectively, actually, this more distal septal might have been a better choice to start with, provided we could wire it, because the proximal one, we don't really have that much space proximal to where the collateral touches down into the proximal vessel. But the wire went easily into that first septal branch, and we decided to pursue it. So here we have a Corsair catheter going all the way into the collateral. And then we had a very hard time, actually, advancing the Corsair further up into the LAD. And this is a case where we took the wire out, we took a little picture. And you see this little tortuosity there. The vessel is small. Probably that's why we're having this difficulty. And this is a very common problem. What do you do when your microcatheter does not cross when the wire does? And there are many ways to deal with this, but the way I like to think about it, at least, is that you can either increase your guide catheter support, or you can increase or modify the septal. So in this particular case, what we did is we put a guide liner. So this is an 8 French guide liner going down the right. And we changed the catheter. This is actually a turnpike. So we took away the Corsair, tried a turnpike. And of course, because we did too many things at once, both the support with the guide liner as well as the different microcatheter, the turnpike, it's hard to know which one did the trick, but in the end, we were able to advance the turnpike catheter almost all the way to the LAD. But then we ran into the problem that we didn't have enough space there and couldn't get the wire to go retrograde. Instead, the wire wanted to go undergrade down in the LAD. So after all this, at least we had the wire as a marker. So what we did here is we let the Sion guide wire be in the proximal LAD as a marker as to where we're going. And then, in a way, that kind of guide us to know where we're going. And this is a guide wire going undergrade, trying to cross into the LAD. However, as you can see here, the patient starts having some hypotension. That was the baseline, and this is what happened after a few minutes later. And of course, when you take a picture, what happened is, trying to advance undergrade wire into the LAD, what we have here is we have some dissection, some injury of the large circumflex branch, and the patient obviously did not like this. So this is one of the potential complications of any PCI, actually, but especially retrograde PCI. You don't want to injure your donor vessel, because that can be a problem. So we ended up putting a stent in the circ, got the flow back. The patient's pressure came back. We actually removed, obviously, the retrograde gear, and this is how the ride looked like. So it's when we're like, whoa, what happened here? But would you stent this at this point, or would you just see how it goes? And the patient, again, is stabilizing now. His pressure is good. His EKG is getting back to normal. And obviously, we're debating whether this is just spasm from having a catheter go through this, or whether we did something wrong to this vessel. But we knew that we had wired easily, and we had not done any aggressive maneuvers on the right. So in my mind, this was all spasm. We just had to wait until the spasm went away. And sure enough, a few minutes later, we gave literally 50 to 100 mics, a tiny amount of nitro into the vessel, and the patient's pressure came back nicely, and he was doing okay. So obviously, at this point, we aborted the procedure, and the idea was that if we're going to do this, we should bring him back and either use an impeller support or put him on ECMO, or we encourage him to consider going for coronary bypass as an option. And actually, the patient decided to go for a single vessel Lima, which he got, and he did very well. But I guess the message of this case is that, CTO or non-CTO, things can go wrong, and being prepared to deal with those is very important. So especially when you go retrograde and you drop a donor vessel in a patient who already has one vessel out, so you're dropping one of the two remaining vessels, that can really, really cause a problem. And retrospectively, actually thinking about this, we should probably have had an impella in this patient to start with as a prophylactic measure. And I think what saved the case here was that we had a nice wire into the circ, so when something happened, we had access to the vessel, we quickly stent, and that took care of the problem. So I think whenever we do any aggressive maneuvers and we are putting any donor vessels at risk, apart from having some hemodynamic support available, then having a safety wire into that donor vessel can come a long way in preventing problems. And I don't know if anyone had any similar things before, but again, this is one of the things that can go wrong during CTO intervention, and it's good to be prepared for it.
Manos, this is Kaushik from Tampa. A quick question I want to ask you. The first time go around when you were trying to attempt this antegrade, what was the wire? I missed that part of what wire did you use when before you went retrograde to go antegrade?
So actually, we tried retrograde first. It's
we
just put a safety. This is a safety wire. What you're seeing here is a safety wire. It's like a regular workhorse wire in the circ.
Okay.
We didn't try at all because the cap was ambiguous, and we were going to clarify that.
Okay.
And then we went in, and initially we took a Fielder XT to go in. This is a ventricular, actually, a ventricular. And then we had a Fielder XT, and then we switched for a Pilot 200, and then we took a Gaia guide wire. And I think it was the Gaia. Gaias are the newer taper tip stiff guide wires. And it was a Gaia second, and I think it's the Gaia that we had the dissection in the circumflex trying to go in. Which I guess is not a wire thing. I think it's mainly that the vessel was diseased and we had a lot of difficulty advancing the wires in, and that's I think why it happened. But it was in the attempt to go into the LAD. And you can see here actually where I think we're subintimal. If you see where the wire is, this is the retrograde wire, which we know is true lumen, and this wire is going on the side. I think the antegrade wire was subintimally in the architecture, but subintimally in that part of the vessel. And again, the difference, I think here, normally when we do escalation, we start with an XT and then we'll go Pilot or Pro 12. I think now the algorithm is changing with the Gaias, and we're using much more early the Gaia wires versus using Confianza Pro 12. It seems a little more torqueable, and it retains its shape a little better than the Confianza Pro 12. I don't know if you had it already or if you're using them, but there seemed to be a major improvement forward.
No, we don't have them here yet.
Okay. Yeah, I think the thing with them is they want you to go for training first.
Yeah. I'm looking forward to you coming here in a couple of weeks to do those 3 cases at Tampa General.
No, we're excited. We're delighted to be there, and I think you guys will do a great job there. Okay. So unless there are any thoughts, we'll just go over another case. And this is from a couple of weeks ago. So this is a right coronary artery CTO. You see collaterals are coming from the left. And this is very similar to the first case in a way that, as you can tell, we have kind of an ambiguous cap. The vessel is tiny little twig that goes forward, but we don't really see much on the undergrade arm. And here's another picture coming from the other side. As you can tell, we tried to go undergrade. This is a Corsair catheter, and this was a Fielder XT wire, I think, initially, and then we tried a Sion wire, and then a Pilot 200. And the wire is not moving according to where we think the distal vessel is. So very similar to the first case, you try to go undergrade first. And I don't know if people saw it, but my philosophy is that in most cases, unless there's absolutely no knob, there's nothing, I will try first undergrade, just even for 5 minutes before going retrograde, because I have been surprised in many cases where you think there's no way undergrade is going to go, and you go for an upfront retrograde, and then retrograde fails, and then you put your undergrade wire in, and within 5 minutes, with an XT, you're true, and you're wondering why did I spend the previous hour trying to go retrograde. So it's been one of those things lately that almost always I'll try very briefly undergrade in most cases, even the ones that seem to be more suitable for retrograde. And if it doesn't work, you didn't lose anything, number one. And number two, even if you go retrograde, you're going to have a subminimal wire undergrade because you're going to use it for your reverse card procedure in the end. So nothing lost, and if anything, you may have a little more efficiency on this. So same things as before, we try to go retrograde. You see there was an old stent in the LAD, but there was a septal further out from the LAD. We can go through stents, but sometimes you may have to dilate the struts to make it easier for the microcatheter to pass. And actually, this was the first case we did with a Micro 14, which is a new microcatheter by Roxwood, which has extra support, and it's a little longer than the current ones. It's 155 centimeters, so a little longer than before. So here is the microcatheter, selective injection. It looks a little funny down there, but it is a septal, and you have a little branches, and actually we didn't have a hard time seeing on guide wire very easily crossed. So there you can see now we got the wire up a little more, and then we're advancing the Micro 14 and very easily going. Actually, we didn't have any hard time at all. Sometimes you have a hard time getting a microcatheter to follow. This one was fairly easy, advancing all the way essentially to the distal cap. And then, because everything was actually very smooth until I took a little picture just to clarify where in the true vessel which we were, and also see what is the angle and where should we go. And actually, what you can see here, the undergrade wire is clearly out, either in acute marginal or somewhere out in the pericardium, but definitely not in the right spot. And what we did in the end, because we couldn't figure out undergrade what was going on, we put a knuckler retrograde, and what you're seeing here is the retrograde guide wire essentially being knuckled all the way up and down to the proximal right. So this vessel actually was very tortuous, and we had not appreciated it, but the vessel goes up and then takes another major bend, and then takes another bend going to the mid. So that's why undergrade was so hard, because I don't think we could appreciate exactly how the vessel architecture was. But with the knuckle, everything went very well. And then now we knew from retrograde wire where to go undergrade, and then now we have an undergrade Corsair with a Fielder XT, and we put a knuckle and was able to advance all the way past the bend. And then we had a pretty hard time, I must admit, getting the reverse card going. So you're seeing here we have an Amplatz one guide, and this is actually a guide liner. There is the guide liner reverse card. I must say we do a lot of guide liner reverse cuts now, because it's much easier to get into the guide liner than try to get the retro wire all the way up and into the undergrade guide catheter. So we put a 6 French guide liner and didn't do it. And then we upsized to an 8 French guide liner, which is a little bigger. And also, I think the most important thing is use a bigger balloon. So we took a 3O balloon, and doing that, then we were able to advance. And actually, maybe you can see the wire is actually pushing on the sides, and then eventually the wire finds its way across the guide liner into the undergrade guide catheter. So had a nice reentry there. RG3 wire externalized, put several regulating stents, and got a nice final result. You can see a little staining there. That's a subintimal dissection we had to do to get to there, but the conus is there. To our surprise, actually, you see all the branches. The acute marginals are there. So we had a nice result in the end, and the patient did really well. So this case again has many interesting things. I think most interesting to me was that the retrograde really helped us when we had the ambiguity in the proximal cap. Using the knuckle, retrograde really helped us understand the vessel, which we couldn't understand going undergrade. Some other people actually recommend doing CT angiogram for this to understand the course of the vessel. But I'm curious if anyone on the call is using CT for this purpose, CT angiogram, for deciding the anatomy and the strategy for a CTO intervention.
I am not, Manos. This is Santiago.
Hey, Santiago. Hey, thanks for joining.
Sure.
So I was actually in a meeting recently, and the Europeans we're really promoting the use of CT to clarify the ambiguity, which I think is not about use, but at least in our setting, it's hard to get a CT. And then even if you do, I'm not sure how you can apply, how you can translate it live into course of a guide wire. And then the last thing is that the guideline reverse card. I was speaking with Bill Lombardi a few days ago, and they do also use guideline reverse card. I would say in the majority of the cases they do, and that has really improved the safety, I think, and the efficiency of getting the retrograde guide wire out there. So I think that's the main things that we have for now. Unless anyone has any other cases that would like to show today.
Yeah, great cases, Manos. I don't have anything in my end.
This is great. So again, and actually another interesting thing to get people's thoughts, we're just looking at the periprocedural MI with dissection re-entry versus retrograde versus undergrade. And I don't know if anyone has any data or if people check their enzymes, but the preliminary data we have is that we have a CKMB 3 times upper limit of normal in like 6% for regular undergrade, 11% for dissection re-entry, and it's like 35 to 40% for retrograde. Which I don't know if people are having similar experiences, but we're kind of surprised by that. So anyway, so this is something that would be looking more into this. But again, thank you all for coming today. Kaushik, thanks again for joining, and Santiago, and hope to see you guys in a couple of weeks. And again, if you have any other case you would like to show or share with other people, please send them to Santiago or I, and we'll be happy to share them. So thanks again very much, and have a great rest of the day.
Thank you. You too, Manos. We'll see you in a few weeks.
All right. Thank you.